my job was to talk on 3 big diabetes trials which had changed the practice recently. It is very difficult to choose, first 3 from a lot of trials. So I thought that why not divide the trials, in the different angle and to understand which 3 trial seems to be at the top as of now. So when you see the anti-diabetic drugs and divide different trials, you need to classify this trial into 4 headings. One, the trial which was conducted to see whether intensive control of blood glucose is beneficial compared to the conventional glucose control. And here comes the first trial called UK-PDS starting in 70s, and then simultaneously Accord Advance and BADT in 2008. When you look back to CB outcome trial, which was mandated by US FDA in 2008, we have got 15 trial results so far, and I'm talking about the placebo control trial, starting from the sebatimie-saxagliptin to the latest trial, which was presented at ADA San Francisco, was the Pioneer 6. So we have 15 CB outcome trials so far. Now the third bullet is the renal outcome trial. We have got 3 big renal endpoint trials, starting with the Credence I just presented in that hall, and to the IMPA renal, to the DEPA CKD. These are 2 other renal endpoint trial which is currently in progress and expected somewhere in 2020-21. And then we have got many heart failure outcome trials which is currently under progress. You can see I have just named few. I will show the entire list of heart failure trials in front of you, and of which the major one is Imperer with empagliflozin with reduced ejection fraction or preserved. Then we have got DEPA heart failure. These 3 trials define, deliver, and DEPA heart failure is with DEPA. Eradicate is a trial with heart failure in artugliflozin, and Soloist heart failure is a trial which is undergoing with sotagliflozin. So this is the data on the different cardiac endpoint trials and renal endpoint trial. Now, if I summarize the CB outcome trial, this is a review paper I published a month back in Indian Journal of Endocrinology and Metabolism. You can go through this paper where you get all the trials, with a rapid view of what happened in this trial through different forest plot. So you have got this CB outcome trial since the 2008 US FDA mandate. We have got 4 trials with DPP-4, you have got 5 trials with SGLT2, you have got 8 trials with GLP-1 and with basal insulin called Devote. The 3 trials on your right hand side which I have marked there was just presented at ADA, so that takes total 15 cardiovascular outcome trial together. So when the organizer, and this is the list of BG slide, don't read, these are the heart failure trials. You can see not one trial, you can see these are the trials which we all are looking in 2020. This is a heart failure trial being conducted with a SGLT2 inhibitor. None of them is published as of now, but these are currently under progress. We expect in 2020 see how many trials doing the heart failure as an endpoint with different SGLT2 inhibitor. So when I have been given the topic to choose 3 CB outcome which I felt is the best and had changed my practice and everyone practice in the world, is the first one in your left hand side, which is the IMPA outcome trial presented and simultaneously published in NEGM and was presented in Stockholm in 2015. In 2016, the liraglutide trial called LEADER was presented, and the IMPA was the first anti-diabetic trial which has shown benefit, and I will take you through what happened in IMPA, and you have already heard several times. The second trial which I choose is the LEADER, the liraglutide, the first GLP-1 trial which shown consistent benefit, and to my knowledge, to my understanding, even better than the IMPA outcome trial, and I will explain you why the LEADER has shown even a better benefit than the IMPA outcome trial. And the third trial, perhaps I would reckon, perhaps on the top is the Credence trial. Even barring IMPA and LEADER, the trial which comes to my mind and which has perhaps shown the door in terms of protecting diabetic kidney disease and heart is the Credence trial. And no wonder the Credence trial is the perhaps only diabetic trial which was stopped prematurely because of excess benefit Normally trials are stopped because of harm. This trial was stopped because of excess benefit. So this is the 3 trial I would choose from my entire CB outcome basket. I will put credence at number 1, leader at number 2, and 3 IMPAREG into in this list. We can argue, but I will make my point why I am putting in this order this list of CB outcome. So let's take first IMPAREG. Needless to say, IMPAREG just shown the way our drugs should have done the benefit, and it has never happened in past that where anti-diabetic drug meant for reducing blood glucose lowers and protect heart primarily and also protect kidney. So you can see there was a 14% reduction in composite of 3-point MES, which is, is the composite of cardiovascular death, MI, and stroke. There was 35% reduction in heart failure, 38% reduction in the cardiovascular death. So for the first time, you have one anti-diabetic drug which protects the heart, which prolongs your life. So there was 38% reduction in the cardiovascular death. No trials in the past prior to this. Take the statin trial. Take even a paradigm heart failure trial with sacubitril valsartan. No trials had shown cardiovascular death against placebo in a tune of 38%. The IMPAREG was the first to show. Not only the CB death, there was 32% reduction in all-cause death, and there was 39% reduction in renal endpoint, although it was the secondary objective of the study. And no wonder why FDA and EMA gave additional level to empagliflozin to be used in a patients with established cardiovascular disease with type 2 diabetes to reduce cardiovascular event. And this was the first anti-diabetic drug to get such an indication from any international organization. So both FDA and EMA gave them an additional level. So the first anti-diabetic drug which got additional level was empagliflozin. The second come is the leader. On your left-hand side, this is the entire trial data from leader. Now, you see in leader, there was 13% reduction in the 3-point MES. In IMPAREG, it was 14%. If you see the cardiovascular death, the leader was the GLP-1 based trial. So that was SGLT2, this is GLP-1 agonist. And again, there was a 22% reduction in the cardiovascular death. It is not as, higher like 38% in the IMPAREG outcome trial, but there was a significant reduction by 22%. Similarly, this drug also reduced the all-cause death by 15% in the leader trial. So you see it seems pretty close to the IMPAREG, right? So you may be wondering why I said that leader should come even before IMPAREG. There has to be some reason behind that. Although the magnitude of benefit in 3-point MES or cardiovascular death or all-cause death was larger in the IMPAREG outcome trial compared to the leader. But as a scientist, as a researcher, we look to the statistical robustness of a trial. I will take you through a little after this. So, and this is the entire leader data. And so needless to say that, as I talked about in summary, there was benefit. Also, there was a protection in the kidney, like the IMPAREG outcome trial. As you saw, in IMPAREG, there was a protection to the kidney. Even in the leader trial, there was a protection to the kidney. So it is pretty similar. Both IMPAREG and leader went in a similar direction, and although two different class, and so showed protection to the heart as well as kidney. But why I said that I will take leader above IMPAREG is because of this statistical power. Now, if you see both leader and IMPAREG, and at that point of time, SUSTAIN was also published when I did this meta-analysis. And you can see, when you see the robustness of a trial, it has to be positive, irrespective of the sensitivity analysis you do. So when you compare the IMPAREG and leader even, this is pretty clear that in terms of robustness from the different sensitivity analysis, leader trial seems to have, showing positivity in whatever kind of sensitivity analysis you do. You can see 3 green graph with the leader, 3 green graph with the SUSTAIN 6, whereas only IMPAREG was positive on an intention to treat analysis. If you do other sensitivity analysis like per protocol or on treatment, IMPAREG remains no longer positive. And that's why reason I said that if I have to choose between even leader and IMPAREG, I will put leader before Impareg. Because of their primary objective robustness, you can see when the p-value in Impareg just achieved significance with p-value of 0.04, whereas in leader it was 0.01, seems to be much robust compared to Impareg. Nevertheless, that's not my topic. I was just wondering whether someone thinks which one was more powerful, and that's why I thought to give you my thought. And that's the reason why liraglutide again got similar approval like the Impareg from the both FDA and EMA. EMA went even further and given additional level for liraglutide even in a primary prevention cohort. For Impareg, this is only a secondary prevention cohort, so Impareg has additional level to be used to reduce cardiovascular risk in a patients with type 2 diabetes with established cardiovascular disease. The similar indication was given to the liraglutide by the FDA, but the EMA went a step further and gave additional level that you can also use it in a primary prevention cohort to reduce cardiovascular disease. Again, you can see that's the reason leader even seems to be more powerful than Impareg to my mind. And no wonder why you see this guideline, the current joint ADA-ESD positioning statement, which has now categorically stated that if your patient has got established cardiovascular disease, if your type 2 diabetic patients had established cardiovascular disease or chronic kidney disease or heart failure, you should prefer either a GLP-1 or SGLT2. This is almost a mandatory indication. There is a, there is no, any exclusion or exception to that. Everyone has got, if anyone has got a cardiovascular disease, if there is no contraindication to use GLP-1 and SGLT2, you should preferably use it. And this was based on Impareg and the leader trial. And then the last one, which I take as a number one, is the credence. Why credence is important? That you see, I have just presented in that tulip hall. Why credence is incredible is, if you see this timeline of different trial in patients with diabetic kidney disease, starting from 2001 to 2019, on your lower hand side, you can see this arrow, which either suggests increased signals, which is in red color, or the blue signals, no benefit in renal endpoint, but no harm either. So you can see, way back in 2001, we had two trials with ARB, losartan, and irbesartan called renal and IDNT, which shown protecting diabetic kidney disease. Since 2001 to 2019, when the credence was presented and published, it took 18 years to have one anti-diabetic drug which could protect kidney. And that's why the credence should come at the top into the list of different cardiorenal endpoint. The beauty is that credence was started even prior to the Impareg, so has no hesitation in having any biasness to show any beneficial data, which was shown later in the Impareg canvas. And it was different because it is predominantly a kidney disease trial, as you can appreciate from eGFR and median urinary albumin creatinine ratio. So primarily, credence is a renal endpoint trial and conducted in a patients who had established kidney disease with eGFR between 30 to 90 and with albumin more than 300 milligram per gram. So this is a mandatory endpoint. The beauty was that it was a primary renal endpoint trial, but it was powered enough to also look for the cardiovascular endpoint, as you can see in the secondary objective. And if you see the result, I don't think any study has shown such a beautiful tick marks in tandem from the statistical point of view. First, it not only achieved the renal endpoint, but then it went on achieving different cardiovascular endpoint, whether it is a heart failure, whether it is a 3-point MACE, or it's a composite of heart failure or cardiovascular death. And you can appreciate the first 5 bullets came positive in the credence trial. It wasn't seen even in any of the trial in the past, and that's why credence is completely different, from the box. What also inspired credence is that benefit not only existed. You see, we had a feeling that this drug doesn't work in a patients with kidney disease, whereas in credence, the benefit extended to someone who has a low eGFR, somewhere between 30 to 45. In fact, they benefited more than the patients with eGFR 60 to 90. And you can see the number needed to treat is only 16 in a patients with a lesser eGFR. And and there was no amputation signal seen like CAN bus, and that's why this is the entire credence result into nutshell. And if you see the number needed to treat, it is pretty smaller than the statin, then the aspirin, then the empagliflozin, then the liraglutide, and that's why the credence should come at number 1 as far as different cardiorenal trial is concerned. No wonder ADA immediately changed their guideline, and on 3rd June, you can see 3 days prior to the ADA started in San Francisco, and they have included now a SGLT2 inhibitor to protect kidney up to eGFR 30. You remember, we were not supposed to prescribe SGLT2 less than 45 eGFR, but now this guideline suggests that it can protect up to eGFR 30, as we saw in the credence trial. So that's why these are the trials which had changed the practice pattern, starting from IMPARIG to LEADER, and now credence. The ADA is, dynamic guidelines is changing every now and then, and that's why I thought this is the 3 biggest trial in my mind. Thank you very much.